Hi everyone. So today we are going to be discussing cervical insufficiency or cervical incompetence. Incompetence, as it's more commonly known, and it's a topic of interest for some of you. Might have experienced it or have been told you have such a diagnosis, and I thought it would be better to give clarity. Also, it was a request from one of you, so here we go. So what is it? Cervical insufficiency is actually a diagnosis of a repeat pregnancy losses. If you have had two or more losses in the second trimester, typically they are painless, and they're associated with just the history will usually be baby just came out or water just came out before 24 to 28 weeks. Okay, but typically we go with 24 weeks. So if you have such a history already, as medics, we start thinking there might be a bit of insufficiency, and what it indicates is that your cervix is unable to hold the pregnancy to term, and the losses usually occur between 18 to 24 weeks. So the cervix has two gates. It has an internal os and an external os. So the gatekeeper is actually the internal os. So if you're looking at it from this side, the internal os is a very thick plug that is able to hold the pregnancy from all the pressures. So how do we know that you have cervical insufficiency? Typically, the history that has just been laid out, that recurrent losses in the second trimester is an history indicator. Then in pregnancy, we typically do ultrasounds, especially the second trimester ultrasound from 18 to 20 weeks. So we check for less than 2.5 centimeters length of the cervix. So to repeat that, less than 2.5 centimeters length or less than 25 millimeters. So if we find that, it is described as cervical shortening. If we find that alone without any history, then we just keep being observant, because some women are able to push through all the way, or we do something that we, but if it's there's history of any loss or very preterm, early preterm baby at around 28 weeks, then we may give a rescue sacrilege. The other thing on ultrasound is you can see funneling. Typically it's supposed to look like this, or a V. It's supposed to look like this. So you find when there's funneling, it becomes a V, then it becomes a Y, and then it becomes a U, then it opens up. Yeah, so V, then Y, because now there's a small outlet for it to come out, and then a U, and then it comes out. So if we find that, then we can be able to do something that we call a rescue sacrilege. Okay, so that is about diagnosis. In the past, we talked about pre-pregnancy diagnosis, where we would check if the cervix is able to pass a dilator, a Hager size 6 or size 8. We would look at that and see if it was passed without any issue. We would to be indicative of cervical incompetence or insufficiency, or we would do a HSG. However, current studies have shown that whether you do it or not in pre-pregnancy state doesn't really confer much benefit, and it's quite uncomfortable really. So we tend to keep it up to check in the second trimester or in the pregnancy itself. So what can make your cervix become weak or incompetent or insufficient? History. So previous history of trauma. How can you get trauma if you've had a previous uterine procedure? For example, an MVA or a manual vacuum aspiration, or a DNC, or typically what we do when we're trying to remove a pregnancy. So if there's that instrumentation and it is excessively done, it can weaken the cervix and actually even cause an insufficiency. if there was trauma during labor, whether it's normal labor, whether it's CS or you did vacuum, if there was trauma during the labor of the cervix, it may lead to insufficiency of the cervix. If at all you've had a previous lip excision or cone biopsy because of a lesion noted in the cervix when a pap smear screening was done, or via villi screening was done, if there's something like that, then that cervix may become weak, may keyword. Then if at all you have labor and then you push before the cervix completely opens up, so you find that in labor we tend to keep insisting, do not push until you're fully dilated. So if there's that abrupt labor before the cervix was ready, then you may actually cause a cervical tear and resultant insufficiency. So that said, how do we go about it? So if we have a history of recurrent losses and it's something that we have foreseen, then we do a scan at around 12 weeks. Then between 12 to 14 weeks we do a cerclage. Cerclage can be either through McDonald's, can be a Shirodka stitch, and then if we start with a McDonald, we find the McDonald's keep failing, then we can go to a Shirodka. If that's failing, we can go a transabdominal cerclage through laparoscopy in a non-pregnancy state. Then the other thing we can do is we do the cerclage or McDonald stitch. We keep you on progesterone up to about 34 to 36 weeks, and then we reduce on physical activity. We may even advise on no coitus for the entire period of the pregnancy. So that's the management. Progesterone, cerclage, and then just observing. If at all in the second trimester we do a scan and we find that the cervix looks short, that is less than 25 millimeters, or we find funneling, the Y and the U I was talking about, then we can do a rescue cerclage, but there should not be an infection. So if at all there's an infection or water has broken, or we find that actually those two mainly, water has broken or there's an infection beforehand, then we don't do a rescue cerclage. We typically treat as we observe, and sometimes even just kind of advise that we do an induction for the safety purposes of the mother, because if you have an infection that has gone to the amniotic fluid, it can give you something we call chorioamnionitis, where the whole back of the uterus plus baby gets infected, and then of course you need to go into the whole bloodstream and affect mother significantly, also the baby. So those are the things that I thought to discuss about. If you have any questions or seeking any clarity, please put it in the comment. Please like, share, and subscribe to the channel, and I hope this helped a mother or two. Thank you very much.